The following is brought to you by the Committee to Protect Healthcare. In the emergency department, we see real-time consequences of people not having access to healthcare. Expansion of Medicaid in Wisconsin would mean less cases to the emergency department. It would prevent closures of hospitals in our communities, and most importantly, save lives. The majority of states in the country have expanded Medicaid with bipartisan support. Yet, legislators in Wisconsin are blocking expansion of Medicaid. They're blocking the opportunity for our patients to have a healthier life.
Tell your legislator to save lives and pass Medicaid expansion.
Welcome to Pulse Check Wisconsin. Good morning, good afternoon, good evening, whatever it may be for you. This is Dr. Ford again with Pulse Check Wisconsin. I want to welcome everybody back for season 2 now, which is very exciting to get into. I hope you guys had a good summer. I know that my crew did here. For all the kids out there, welcome back to another school year. I wish you all the best, specifically all the kids that are starting on the date of this recording, which is September 3rd. I believe all the Milwaukee public schools are back in session. So best of luck to you guys this year. You're going to do amazing things. Looking forward to all the things that you will accomplish, all the bright minds here in Milwaukee and throughout Wisconsin. We got a good episode for you here today. We are going to have with us a cardiologist who is also a contributor to a number of news outlets. Her name is Dr. Morgan. She is a cardiologist. She's an African-American cardiologist who specializes in being an outlet to the public and sharing with us some of her expertise, some of her specialty specifics as well. And we're very fortunate to have her here today. We're going to get into a couple of topics regarding cardiology in general. Cardiology affects multiple populations throughout the state of Wisconsin, specifically underserved minority populations as well. We see a disproportionate amount of bad outcomes related to heart failure, related to heart attacks, exacerbations associated with high blood pressure, diabetes, things of that nature. So I want to do everything that we can to skew these numbers. So with that being said, what we're going to do is we're going to get started with one of our cases. This case will be a case that I saw in the emergency department. This was right around the time of COVID-19. So the hospitals had been seeing less volume at the very beginning of the pandemic because a lot of folks stayed home. So I won't give too much away. We'll go ahead and get into our first case. Patient is a 64-year-old female who is presenting to the emergency department with concerns of nausea, vomiting, and some tooth pain along the left jawline. The patient states that this pain started roughly a couple days ago. She was at home and noted that she had some pain. She was going to make an appointment with her dentist coming up. Patient denies any fevers at home. She denies any chest pain. She denies any difficulty breathing, but states that today she started to get increasingly nauseous, felt as though she was going to throw up, and as such thought that she could be having an infection of a tooth that maybe caused any symptoms. When patient came back to the emergency department room, she was noted to be afebrile, meaning she didn't have a fever. She was still nauseated, and she just appeared to be not well. Her skin color was a little bit grayish. She looked as though she was volume down, meaning that she looked dehydrated. She had a tachycardic heart rate to the 120s, Usually heart rate normally is sitting somewhere between 60s and 90s. Anything above 100 we consider to be a fast heart rate or a tachycardic heart rate. She had a blood pressure which was lower. Her blood pressure was in the 80s systolic. We usually want to see that above 90. Again, this was during the pandemic. So in the very beginning, family members were allowed in the room. Towards kind of the middle of the pandemic, family members were not allowed. But in this case, we brought the family members back, just how unwell that she looked and the fact they could provide a little bit more history. Patient had no cardiac history. She was only taking medications for blood pressure. But that was about it. I noticed that her heart rate was fluctuating. It was going from 120 to 140 to 160. And again, the striking thing was that her blood pressure was exceptionally low. As such, we got an EKG for her that showed an irregular heart rhythm, which was atrial fibrillation. With the patient's blood pressure being low, we placed some pace pads on her. We got a formal EKG performed for the patient as well to determine, aside from the atrial fibrillation, if there was anything else going on. We explained all this to the patient and why we were placing these pads, because in some cases you will see that irregular heart rate itself can cause the blood pressure to be low. And in those cases, sometimes we need to shock the heart back into a normal rhythm. As I was taking a look at her EKG, I noted that it was something familiar, but something that looked to be concerning outright. It looked as though she had what we call ST elevation, or a segment of the EKG that looks concerning for a heart attack. I went back and talked to the patient again. The patient stated again that she had no chest pain, she had no difficulty breathing, and was just the tooth pain and the nausea. We ordered some labs for the patient, and while we were waiting on that, after her fluid was completed, I didn't like the fact that the patient's blood pressure still was low, so we ended up placing a central line for the patient. A central line is a line that we can use in order to provide some medication to the patient to bring the blood pressure up. We had discussion with the patient if she would want to be cardioverted, meaning to shock the heart, and she did not want to do that. And with this ST elevation, my concern was that there was something else going on as well. I took a look with an ultrasound at bedside for the patient. We're able to do this in the emergency departments. Just with a bedside ultrasound, we're able to take a look at your heart in real time. And what it looked like was a portion of her heart, her right ventricle, was not beating as well as the left side of her heart, and it appeared to be dilated as well. After we placed the central line, we ended up having our cardiology colleagues come down and see the patient. We started the patient on what we call vasopressors, or medications to improve the blood pressure. I shared with our cardiology colleagues that I was concerned that this patient may have had a heart attack. And after talking with her again in the beginning of the story, it seems as though her symptoms started a couple days ago. The cardiologist agreed with this and was also concerned that the patient not only had a heart attack, but may have had this heart attack 2 days prior when the symptoms first began. What we were seeing in this patient's case was what the eventual diagnosis was. Not only did she have a heart attack, but she also had what we know as cardiogenic shock. So this patient's case is really interesting, and it really underlines one of the things that we talk about in cardiology as well as in emergency medicine. Both cardiology and emergency medicine doctors see an exorbitant amount of EKGs every day. Cardiologists may see more in the clinic. However, in the emergency department, the average ER doctor that's at a level 1 center or at a large metropolitan area center may see up to 30, 40 plus EKGs every day. In those cases, we have to be really good at picking up things that are concerning, because in these cases, you only have seconds to minutes in order to make a decision as to what to do with those patients next, and if a patient is at increased risk, if we need to move on it. In this patient's case, again, she did not have any typical chest pain. And this is something in recent years, I would say in the last 10, 15 years, that we have harped on as a medical discipline as well as educators in medicine that women typically don't have the typical crushing chest pain, stabbing chest pain with radiation up through the jaw or down the arm. In fact, in this patient's case, the chest pain actually had an equivalent, or we call it chest pain equivalent, which was nausea. And in addition, she had that tooth pain on the left. It's been well documented in recent years that women will have different presentations to heart attacks than men. And in this case, this was similar to what we're seeing in multiple chart reviews that we've done. This atypical pain to the jaw or to the tooth, or it could even be just feeling fatigued or feeling weak or feeling nauseated. In this patient's case, again, because COVID hit us so hard, folks were afraid to come to the emergency department. In some cases, folks were told to not come to the emergency department unless they felt as though there was an emergency, just given how overran we were at the beginning of the pandemic and how little we actually knew about COVID-19. In her case, what happened was she actually had a heart attack 2 days prior. And what happens commonly is if you have that heart attack over time, that heart muscle will be affected. A heart attack effectively is when you have a portion of your heart that is not getting enough blood supply through a thrombus or some blockage that's causing that decreased blood flow. In her case, she had decreased blockage to that right heart, and that was the abnormality that we were seeing on the ultrasound. What happens is the muscle becomes what we call ischemic, or doesn't get blood to it, and so over time that muscle begins to break down. And with it, the functionality of the heart begins to erode as well. We were seeing on the formal ultrasound that we were able to get at bedside, she had some valvular abnormalities. Subsequently, what happened was this affected not only what we call the ionotropy, or the squeeze of the heart, but also affected some of the chronotropy, or how fast the heart was going. It affected the electrical signal pathway that the heart typically undergoes, which was why she was in that dysrhythmia, that atrial fibrillation. In addition, as we mentioned before, this patient had what we call cardiogenic shock, or essentially the heart not functioning as well as it can. And so you can see fluctuations in blood pressure. She had a very low blood pressure. And this is a condition that can be exceptionally dangerous. In fact, this patient not only was taken to the cath lab, she was admitted to a cardiac ICU following. Fortunately for this patient, she had a great outcome. She was able to have cardiac stents placed. She was able to follow up as an outpatient with our cardiologist and our electrophysiologist. And as of the last access that I had to her chart, she was back at home. So this case in itself underlines the importance of a couple things. So first off, for all women who have a family history of heart disorder or any cardiac disorders, diabetes, hypertension, if you have a strong family history as well, you want to make sure that you're looking out for when things are not feeling well. Because again, a lot of times you're not going to have that typical crushing chest pain, typical radiation of the pain up the jaw or down the arm. There may be more subtle presentations, like in this patient's case when she had some nausea associated with it. And there are some contextual reasons for this that we'll get into when we speak with Dr. Morgan as to why we are just now taking a look at the differences between men and women and their presentations with heart attacks. So make sure that you're on the lookout for those symptoms. Make sure that you are checking in either with your doctor or go to the emergency department if you're experiencing something that just doesn't feel right. Secondarily, you want to make sure that you're seeing your cardiologist or seeing your doctor regularly as much as possible. During the season, we're going to talk about the importance of primary care, a couple good primary care clinics in the Milwaukee area to make sure that we get to you before your presentation gets to this point, making sure that we're optimizing your healthcare as much as possible. So that was our case. Now I want to open up the conversation with our special guest for the day, Dr. Morgan, who is going to discuss with us some very high yield concepts in cardiology. We're so lucky to have her here, and we'll go ahead and start.
My name is Dr. Jayne Morgan. I'm a cardiologist. A lot of my background has been really in research. I came up through the industry, really pharma industry, device industry, doing real R&D, hard, research and development, writing protocols, enrolling people in trials, traveling, identifying study sites. So that bread and butter grunt work of how drugs come to market. I did that for a number of years. I practiced both before that and after that. And then even was at Piedmont Healthcare, which is the largest healthcare system in the state of Georgia, for 9 years, leading their cardiovascular research program. And then for COVID, being the head of the COVID task force. And then really branching off quite a bit into brand growth and marketing. Currently, I'm the vice president of medical affairs for Hello Heart, which is a digital health company focused on hypertension, reducing heart disease. It is an that you use to control your blood pressure, but also interact with that app, get real data and information. And we're looking to really close the gap, especially in healthcare for women and for minority populations who oftentimes are not getting accurate information, not getting timely information. We don't feel empowered to ask the questions. Well, now we've got an app that can help guide you through all of that and even direct you for when you need to go to the physician. I do a lot on social media. I have a series called the Stairwell Chronicles, which I usually post on Wednesdays. And I sit on my stairs and give one piece of medical advice in 60 seconds or less. I usually ask a question of myself and answer it in 60 seconds. I like to say that's my house because it is. Those are my stairs. Those are my clothes. That's my question. So if you ever submit questions, I might answer your questions as well. I talk a lot about cardiology and clinical trials and research and health equity and women's health, but also all kinds of other things as well. And then other places you may see me is I do quite a bit of media interviews, doing medical analysis. I do that for CNN, for Scripps News, for the Weather Channel even, for ABC News affiliates, WSB TV. So you may see me doing those as well, just kind of breaking down complex science information, making it relatable to the public and explaining it on media.
I initially came across you just, like you said, through some of those media interviews, especially your staircase series as well. And just some of the questions that you were answering and some of the information that you were giving out, I thought would be perfect for our audience because I often get asked in the emergency department some of these very same questions. And so, I appreciate all the amazing things that you're doing, both in the community. I'm sure the state of Georgia would say the same as well, but I want to thank you.
Yeah, no, thank you, Dr. Ford. And I appreciate being on today. And if anybody wants to follow me, I'm at Dr. Jayne Morgan. It's just Drjayne. I've got a Y in my first name. And then Morgan. I had nothing to do with it. I was born. That's the way it was. So Dr. Jayne Morgan, Instagram, X, Threads, TikTok. And I'm on LinkedIn as well. Please, I do a lot of professional posts. Jayne Morgan, MD.
Definitely follow. So, we'll go ahead and kick off here. What inspired you to pursue a career in cardiology? And before we get in that, happy Women in Healthcare Month as well.
Yeah. When I came into medicine, maybe it was kind of interesting. And even before I went into cardiology, where I was growing up, my neighbors on either side of us, we had a family practitioner lived on one side of us. The other side of us was a dermatologist. Across the street was an orthopedic surgeon. And then the next house down was another orthopedic surgeon. And then around the corner was a dentist, and I babysat for them. And so we had so many professionals just right there in our environment. I was playing with their children. My parents were not physicians, My mother was a tenured professor at Spelman College, and my father was sort of upper level management at the U.S. Post Office. Both of my parents worked and worked full time in order for us to live there in that neighborhood. Whereas the other homes with the physicians, they were all male physicians. The men worked, and the wives were stay at home wives, and many of them also had housekeepers. So
Mm,
we lived there as well, but both of my parents worked.
mm,
We were latchkey kids. I came home, there was no housekeeper waiting for me. But what I would see in that is that my best friend across the street, her name was Gina Scott, I would go to their house and play. Her father was an orthopedic surgeon. He would have all his books down in his office, and we were never supposed to go in there. So, of course, we loved sneaking in there. And
mhm,
I would like to open his books and look at all those really icky pictures of those weird diseases and those people. And I think it was there that I started to develop an interest because those books, as much as they kind of repulsed me, they were fascinating. I always wanted to
mhm.
come and look at them. And I wasn't reading them. I just was looking at the pictures. I had never seen people that looked like this and diseases like that.
Right.
So when I went to med school, I actually went to medical school to become an orthopedic surgeon because I don't know, that's all I knew, right? Doctors or orthopedic surgeons. And then of course, your world opens and your world expands. You start learning about things you never heard of, rheumatology and,
Mhm.
psychiatry. And so I started going through these rotations. Every time I went through a rotation, I was thinking, I think I want to be that. Oh, it's
Yeah.
interesting. So I was changing my mind. I was all over the place. I was a chameleon. So I ended up going into internal medicine because, you know, who could make a decision?
Yeah.
Just too, right? So
Mhm.
did internal medicine. And I was there and I was kind of thinking, maybe I'll just be a general practitioner, maybe I'll be an intern. And I started doing critical care rotations and I liked critical care a lot. I liked the
Mm.
ICU. I wasn't so in love with pulmonary though, but I liked critical care. And then I did cardiology and cardiology. I really liked cardiology and it combined the critical care. And so really I went into cardiology just by being open to exploring my world and exploring my profession and learning and not being set in one thing and being able to grow and being willing to grow. And in doing so, I discovered cardiology.
Mhm.
So I went to med school to become an orthopedic surgeon. And hello, I am a research cardiologist.
And we see that so often, right? Especially there's a lot of medical students. We just had someone that are participating in a program where they're taking kids from the inner city of Milwaukee and they're doing a pathway to medical school just to kind of get that representation there. And you see it in so many medical students. You come in with the idea that you're going to be one thing. And
Right.
it's not until you kind of walk that walk and you kind of see what you want to do. My story was the same way personally. I loved everything that I saw. Like, oh,
Mhm.
pediatrics, oh, I love that. Oh, surgery, oh yeah, I want to do all that. And it
Right.
wasn't until third or fourth year where I was like, oh, I really like just going to the emergency department for all the consults. So why don't I
Mhm.
just do that, right? So yeah, that's a good point. You guys just don't come fixing your ways. Just be open, and you never know where you may end up.
That's right. Because, it's a great example of life. Sometimes you only know what you know. And
Exactly.
you don't know what you don't know. So always
Hmm.
be willing. I like to say, even today, that I am a forever student of medicine. There's
Yeah.
always something to learn. I'm never a master. I'm always a student. And I came to cardiology from orthopedic surgery because I was always a student. And as long as you're always willing to learn and evolve, then you don't really know where you will end up in life.
You got it. And one of the things you brought up there too was, the ability to see, right? The ability to grow up in a neighborhood where you could see folks who were orthopedic
Yeah.
surgeons or see folks who were physicians.
Right.
Coming up as a cardiologist or at least a cardiologist in training,
Mhm.
our numbers in terms of African Americans in general, as well as African American women are very finite.
That's right.
What what if any challenges did you experience just being an African American woman coming up through the cardiology ranks did you experience and what how did you overcome them in those roles?
And I recognize, after I had grown up, that my upbringing was somewhat unusual, just to be
Mm,
surrounded by homes of physicians. And it was only then, when looking back, when I started to make comparisons, as I said, that we were there, but both of our parents were working. A lot of those kids in the other houses were in private schools. I went to public school. the fact of the matter is we were still living in that neighborhood, and it shaped you. And it was only when I became older that I realized there were some people who had never even met a Black doctor, who had
Right.
never even seen a Black doctor. And then when I look back on it, I didn't see any female doctors. Every physician in our neighborhood, including the dentist, were all men.
Wow.
So in that way, I had no role model. And in fact, when I look back on it, I originally was thinking I wanted to be a nurse because I thought men were doctors and women were nurses. I don't know where I got that in my head, but maybe TV or
Right.
society somehow. I didn't see it. So sometimes you can't be it if you can't see it.
Right.
And so in that way, my neighborhood was very helpful in shaping the idea that I could be something, and I didn't realize that it wasn't something that I could be, and that there were people in the world who've never even seen Black doctors, and here I am living in a whole neighborhood of them. I didn't
Right.
know that, and this is what I'm saying. You don't know what you don't know. And so later, when I became a cardiologist, when I say there are very few Black female cardiologists, I really didn't know any. I knew
Mm-mm.
myself. I didn't know anybody else. I joined an organization called the Association of Black Cardiologists and met some others. And then I'll tell you an eye-opening experience. I came to Piedmont Healthcare, and that was in 2015. And when I walked in, there were, oh my gosh, were there 6 Black physicians? Like, you could have knocked me over with a feather. I don't even know
Mm-hmm.
if I ever in my life even been in a room with that many. Did I even know that many? We had, let's see, Tara Rabowski was in heart failure. We had another male there in heart failure. We had a surgeon, a female cardiac surgeon. Let's see, David Montgomery was there in cardiology. Out of Morehouse, I came out of Spelman. So,
Mm.
we are connected. They
Shout
were,
out Spells.
I was amazed
Mm-hmm.
at the richness of that environment. And, just many topics that maybe we'll get into today, none of those doctors are even there today.
Mm.
And if medical environments are not conducive to support the Black physician, the Black specialist physician, even the rarity of seeing Black cardiologists and having a cluster of them at one institution, it was not even recognized as something that was so special and abnormal. And one
Mm.
by one, all of those doctors have gone on to do other things when there was an opportunity for there to be something so incredibly special there at that time of cardiologists. Black female cardiologists make up less than 1% of the profession. And at the time, I think there were 3 or 4 at one institution,
Wow.
right?
Wow.
I had never even seen that many,
No.
and one institution had them, but the value wasn't there. I don't think people recognized that this was it was something that had happened by happenstance, right? It was not intentional, just by happenstance. All of these physicians were there. We recognized it amongst each other, but the big institution didn't recognize how rare and what a very special cluster of physicians they had and how rare it was to have them. And so that's a great example of they're all gone. It's hard. It is difficult. You're not valued. You're not seen as something special. You are othered.
Mm-hmm.
And you're othered in very subtle ways that erode your ability to have a great quality of life, that interfere with your ability to give your patients the care that you really know they need, and that sometimes only you can give them from a
Right.
culturally congruent perspective.
Mm-hmm.
Probably stay longer than you should because you're dedicated to your patients, even though it's not working for you. So these are all things that we grapple with all the time. Our commitment and dedication to our community versus what commitment do I have to myself if
Yep.
it's not moving forward? And so, I think Black physicians in particular are always in that sort of quagmire of the yin and the yang.
Yeah. And you brought up a couple of good points there. One thing is that a lot of those physicians we're losing, right? Like we're losing them to other institutions, if they feel as though that pressure is too much or if they feel unsupported. A
Right.
lot of times we see, when I started in my hospital I'm at currently, we have maybe 3 or 4 African American doctors, period, right?
Period. Not
And
even
now,
cardiac.
period. Right? And
And you
so,
got to mention cardiology. And then I will say, I'm sorry, I forgot the
no, no,
name.
no, go for it. Yep.
Blanking on the names. Dr. Kelly McCants was there. Dr. Africa Wallace was there. Tara
Mhm.
Rabowski, David Montgomery. They were all Black doctors. Jayne Morgan showed up in
Right.
research. And let me tell you something. The Black cardiologists who were there when I arrived had never seen a Black cardiology
Mm-mm.
researcher. Like they
Mm-mm.
all came over to go, oh my gosh, you're doing research. We've never met somebody who's doing research. It was so special. And yet we recognized how hard it was because the bigger institution didn't value how
Exactly.
special it really was. And all of us were having such challenges just maintaining what we were doing. And here you are, just as you said, Dr. Ford, you're at your institution, let alone specialists. You all didn't even have four
That's it.
doctors.
That's it. Right. And it's so rare because one of the other things that we'll kind of segue into our next question is how important that is, not only from a physician just having you there to see, right, for patients to see, kids to see in the community, et cetera, but taking away even the color aspect, it's the cultural aspect, right? And you made mention of that too. Understanding the culture, understanding where people are coming from has been shown objectively to improve
Mhm.
patient outcomes in a lot of
Sure.
situations. And so it just going from that, how has your background and how have where you come from, kind of from a cultural standpoint, how do you feel that that's influenced your approach to your perspective on medicine, you being a cardiologist, and taking that extra step for your patients?
I thought originally it wasn't an impact. And I think because I was determined to say, I'm not going to be othered. I am a physician and I deserve to be here and I am going to be in the mainstream and this is how it is. And I'm not going to look at everything from a Black lens because I have arrived and I am not going to be othered. So I'm not going to raise my hand. But yet, there are things that you unseen as you're going through that. You
Yep.
cannot speak on them, but you can't unsee them.
Hmm.
And, you know, dermatology, I mean, that was just insane. I mean, at one point I asked my professor, what does this look like on Black skin? And my answer was, just like this. No, just this is not the answer. That's what it's going to look like on our skin. I mean, just everything, the formulas that we were dealing with, why is there a race factor in there? Well, because, we know Blacks retain water, but what do you mean they retain? What does that mean? I mean, and I was just allowing the system to give me these non-answer answers. But mostly in my defense, I'm going to defend myself a little bit. You're powerless.
Yep.
You're a cog in the wheel. I need these people so I can finish my degree. I need to finish my medicine rotation, my medicine residence. I've got to do my cardiology. I'm not trying to argue with people or, look as if you're the angry Black female or
Uh-huh.
you're challenging. So you're constantly stepping back when you really should be stepping forward. And you have a
Right.
reason to step forward. You have a reason to challenge the system and
Mhm.
just say, hey, this isn't right. This is not going to work. This is going to triage my people to lower levels of care and concern. I
Mhm.
see that and I know that. And yet, the exact same situation myself and other physicians found ourselves in. We're at this big medical institution that doesn't really value the specialness of having all of us together. Do you stay for your patients because you
Right.
know they're not going to get that lens if you leave, but on the other hand, it's killing your soul?
Yep.
What
Mhm.
do you do? Do you leave and leave your patients and you know that they will be abandoned? Or so we're always in that. I mean, in that situation, even all through medical school for me. Do I speak up and risk looking like the angry Black male
Mhm.
angry Black female, or they start to, marginalize me or it becomes more difficult for me to graduate? I need
Uh-huh.
these people to get through. Let me just go along to get along and keep my mouth quiet.
Yeah.
So, and yet you can't unsee it,
Mhm.
right?
Mhm.
So here we are.
Here we are. And that's so true. One time I remember the very first time I spoke out in training was during an M&M conference. For those that are listening, we have a morbidity and mortality conference where we kind of talk about cases that we can learn from or cases that didn't go well, et cetera.
Right.
And so during that conversation, there was someone who was presenting who was not African American. Again, I was one of maybe a handful in the hospital. And during that, it was brought up right before the case, African American male comes in, gets shot. Of course he was going to Bible study. Of course he was doing this. And of course he was totally innocent. And then everybody chuckled and they went on. Right.
Right.
And so
Right. It's that
it was
that sarcasm.
exactly, exactly. And so it was brewing inside of me the whole time because, I grew up on the South Side of Chicago. I've been out with friends, when I was growing up that either got shot at or got shot.
Mhm.
And we were going to football practice, right?
Right.
Like we were going to X, Y, and
Right.
Z, right? We
Right.
weren't involved in anything. And so it wasn't until the very end that I could not hold it in anymore. Because like you
Right.
said, this is through college, through
That's right.
medical school when you're powerless. And I said, you know what? To hell with it. If I get in trouble, I get in trouble. And I stood up and I said, I don't know if this is, if I can say this in this fashion, but I cannot stand for this anymore. The way that we interpret and the way that we walk around and speak trickles down to our patients. It trickles
That's
down
right.
to our nurses, to our tech. And you
That's right.
have that African American male in the trauma bay and you're moving slower, or you're not
That's
giving pain medication,
There you
or you're
go.
not doing the follow-up care.
There
You're
you
not doing
go.
X, Y,
You're
and
just
Z.
listening in because the system and the culture will support it, and
Yep.
you can chuckle about it.
Mm-hmm.
That's
Yep.
why Black doctors stay in jobs longer than they should,
Yep.
because you're worried about your patients more than yourself. And we're the only race that has to deal with that. Should I stay or should I go?
Yeah. Yeah. And, I will say I was very fortunate to be in a program that was applauded. And, we actually did a couple of series after that talking about, cultural competency, et cetera. But that is in the minority. Right? Like those institutions.
Absolutely.
And so you always have to be looking over your shoulder and
And
saying,
how
am I
sad
going to do
for
this?
you to have to speak up and know you're taking a risk.
Right. Exactly.
There's that, a risk. You have to take a risk. We are the only race that constantly, as physicians, are having to balance that risk benefit ratio with
Hmm.
ourselves versus our patient. And where's our commitment today? And if I take this risk and I am penalized, then what service am I to my patients if I no longer can serve them because I've been whatever, dismissed or disciplined so maybe I keep my mouth shut just so I can keep seeing my patient, but then the system doesn't change. And that's what, so we just go round and round. And the fact of the matter is you speaking up meant you were taking a personal and professional risk.
Absolutely.
And that is not how it should be. It worked out for you, but it was a risk
It's a
that
risk.
you decided to take, and it could have gone badly.
Hmm.
Mhm.
Hmm. Well, this is why we do this podcast. I appreciate you, Dr.
Right.
Morris, for coming out so we can have these
Right.
discussions here, because that candid discussion is how we get through a lot of the issues that we see in healthcare. One of the things that I wanted to touch on is just kind of your perspective on cardiology in general. You talked about the app, and we'll make sure that we get it on our website, as well as pass it out to all of our listeners. But involving minority communities with cardiology specifically, what are some of the most pressing issues that you see as a cardiologist today?
Yeah. Regarding minority, the biggest issues are obesity and hypertension. I mean, it's just bread and butter, right?
Mhm.
And we know now that inflammatory conditions are actually the predicators of developing heart disease. Obesity causes chronic inflammation in the body. And yet, obesity is so complicated because it is often driven by money.
Mhm.
It costs money to eat fruits and vegetables, to eat organic foods. If you haven't gotten a good education, you don't have a good job, or let's just say you do have an education and you've been able to get a job, but you haven't been able to get promoted. You're not
Mhm.
going to be moved up in the ranks. You always will stay where you are, and people will move beyond you. It limits your ability to make choices. And those choices include the kinds of foods you eat. Those choices will include the type of neighborhood you live in and
Mm.
whether or not you'll be able to exercise outside and have access to park and walkable areas. It will impact your choices that will then impact your longevity.
Absolutely.
And those are the things, those are the connections that we have to start to make. Obesity is driven not only by overconsumption of calories, but by cheap food, processed food, readily available food, tasty foods, foods
Mhm.
loaded with chemicals. Why are those chemicals there? Those chemicals there to improve the texture,
Yeah.
make it more palatable, give it a nice color. You
Yeah.
crave it more. And so then these are empty calories. We call those empty calories, and they just kind of feed on themselves. I think obesity is huge. And then hypertension is the next one. Hypertension, because it is the most undiagnosed condition, not only in the United States within our community, but also in the United States. Most can still be easily treated. But listen, I have never treated a blood pressure that wasn't first diagnosed.
Mhm.
And most of them are still undiagnosed.
Yep.
So now we're back to kind of the app that I'm dealing with, but also just if you're seeing your physician and you have been prescribed medications, take your medication. And
Yep.
then get your follow-up appointment and make certain we can treat your blood pressure to goal. When we say to goal, that means that top number needs to be 120 or ideally maybe even a little less. Not 140, 133. Oh, it's good enough. It's okay. If your doctor tells you it's okay, that's no bueno.
No.
We don't want
No.
somebody to tell you it's okay. Okay is code for good enough for you.
Mhm. Mhm.
Okay. You think okay means that it's okay, but doctor speak means is good enough for you. It needs to be 120 or less, that top number. And that's what you need to say, but doctor, it's 133. I was listening to a podcast with Dr. Ford and Dr. Ford, and they told me that you were supposed to treat me until it got to 120. So I need you to do that. And
Yep.
that's the top number, and the bottom number needs to be 80. We need to stop accepting okay. And it's not our fault because okay generally means that it's okay. But in science, that's not what it means when someone's telling you
Yep.
okay.
It's a 0 or 1, right? It's a yes or no. Yeah.
Right.
Yes. No, and that's so true. And a lot of times too, what folks don't understand is that, especially in the cases of hypertension, it's that silent killer, right? And so until it becomes an issue where you come and see me in the emergency department, and then I consult, Dr. Morgan to come down and check on you if something's going on, you are walking around day to day and not feeling any effects from it, or maybe every now and then, but not every day. And so it's
Right.
very important to take those
Just
medications. It's important
slowly
if you don't have
kill you.
exactly if you don't have access to those medications, there are programs, especially now with, we have been doing a couple of things with the Inflation Reduction Act that some
Right.
medications have become more affordable. So make sure that you're checking all those lists. If you can't afford your medication, do not skip them. Please, please, please don't
That's
skip
it.
them.
And the single most important thing you can do for yourself is if you're smoking cigarettes to stop smoking. And it's
Mm,
especially important for women because the deleterious or bad effects of cigarette smoking have a higher propensity. We call that propensity index in women than in men for the same number of cigarette smoking. And there are about 4 traditional cardiac, meaning heart factors, 4 traditional risk factors for heart disease that actually, if you have them as a woman, you've got a higher propensity index, meaning they're going to have more of a negative effect on you than they will on your brother with the
mm,
exact same numbers. Obesity is one of them. The other, cigarette smoking. The other one is diabetes. In fact, men who are diagnosed with diabetes have twice the risk of dying from heart
mm,
disease, but women diagnosed with diabetes have 3 times the risk. And then the last one is cholesterol. These are traditional risk factors for everybody. They have a higher propensity index, they have a higher rate of having bad outcomes in women than in men. And so we need to make certain that these are things that we really try to modify. We talk about that diet all the time, exercise, things that you can do with your lifestyle and avoid medication. But if you're prescribed medications, please take them. Don't say, oh, I'm not going to take it. I'm just going to exercise. No, take it because for some reason you're being diagnosed now. Go ahead and exercise. And then later, if you don't need them, we can remove
You do it.
them.
Exactly. 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 One of the things that we talked about here are those risk factors. So you said obesity, smoking can put you at higher risk of some cardiovascular conditions. What are some of the cardiovascular conditions that you're seeing that are disproportionately affecting the African American community?
Yeah, hey, let's talk about it. Hypertensive diseases of pregnancy. We'll talk about that. You have been diagnosed with hypertension in pregnancy. Sometimes they use these terms like preeclampsia or eclampsia or something like that, or even diabetes. Do you know that if you are diagnosed with diabetes during your pregnancy, your risk of heart disease is higher than a woman who has not been diagnosed for the next 25 years after the delivery of that baby? Not only that, if you have been diagnosed with any hypertensive disorders, you should follow up with a cardiologist because your long-term risk is going to be higher. And what we've seen as in the entire biochemical milieu is that if you're diagnosed with hypertension, you end up with an aberration in your cholesterol profile, your triglycerides, your LDL, your HDL. So for some reason, that hypertension or preeclampsia is a marker other things that are happening in your body. That is a wake-up call. The stress test is actually the pregnancy is actually the very first stress test that a woman will have. So here is something, if you all don't get anything else from our talk today, I want you to make certain, especially women, that whenever you go to the physician between now and the rest of your life, you give them your obstetric history, meaning your pregnancy history. And if they don't ask before the doctor leaves the room, say, doctor, don't you want to hear my pregnancy history?
Be your advocate. Be your own advocate.
And then you give it to them because that can drive and determine the type of care and concern that you receive later. Pregnancy is your first stress test, and it can mark you for things and cardiac events that could happen later. And we have an opportunity to intervene early. And whenever you go to the doctor, that doctor needs to know your obstetrical history because it will should guide their thought process. If they don't ask, you need to just give it to. I'm just going to help you. Let me help you help me.
Absolutely.
Yeah.
Absolutely. And to drive that home for listeners here in Milwaukee, we recently, a couple of years back, I believe it was right before the pandemic, we had an African-American young lady who had a cardiac condition, heart failure associated with her pregnancy. They ended up dying in one of our emergency departments here. And they did not know that until after the fact. They went back through her chart and saw that someone had diagnosed her with a cardiomyopathy or a cardiac condition associated with her pregnancy. So that's just driving Dr. Morgan's point home to say this happens often. And again, these are things that, your doctor, if you bring it up, they can look into it. They can do those tests as an outpatient. They can schedule you. You go to a clinic, office during the day and get that ultrasound done. And then or you don't know. But it's key that you have that evaluation done before it's too late.
Right.
Yeah. So Dr. Morgan, what?
Else home, take that with you today.
Exactly. Take it with you.
Yeah.
One of the things that we talked about, we did a case beforehand. And in that case, it was a case of a 60-year-old woman who came in with tooth pain as well as some nausea associated with it. At the end of the day, it ended up being that she had an MI, a heart attack, and actually stayed home for a while. So she was actually, unfortunately, in cardiogenic shock. A lot of that point was to drive home the fact that for women, myocardial infarctions or heart attacks present a lot differently than they do typically for men. Could you talk about that a little bit and what your experience has been in those differences of presentation?
And that's right. And women can also present with the
Absolutely.
It's
Absolutely.
pain, it's shortness of breath, but then we can have this other stuff too.
Mm-hmm.
And here's something I want to go back to our med school when I talk about things where we were just like pressing our lips together, but not
Yeah.
saying, I don't even know how to start it. When what Dr. Ford is talking about, these symptoms of jaw pain, tooth pain, nausea, back pain, flu-like symptoms, which actually could be symptoms of heart disease in women. In medical school and in training, and even in my cardiology fellowship, those symptoms are referred to as typical. They are assigned the word atypical. This is how you chart it. It is the standard nomenclature.
Mm-hmm.
Now, just think about how words and descriptions drive thoughts and actions. And by describing it as atypical, it's another way to other it as important, something additional. We have time, we might learn it, but we're not going to be tested. It's going to be the main thing. We're going to other that. Well, here's my thought on that. Women are 51% of the population. We are the majority of the population. How did our symptoms get to be atypical? So maybe we're having the more standard symptoms, and it's like the men who need to be othered. No
Hey.
offense to Dr. Sim.
No. I agree. Absolutely.
So I'm just saying another example. I could give you hundreds, as I know Dr. Ford could, going through medical school and training where you're just like, I'm just going to keep my mouth shut. I'm not going to say anything. I didn't go into gynecology for a number of reasons, but one of them is that, they name things like your cervix, an incompetent cervix, the shy bladder, that all these, I just was like, oh, does anybody not feeling nauseous as we're going
Right.
through? Right. Why does a woman's cervix have to be incompetent? There's no part of the man's body nor condition that we term as being incompetent.
Hey.
So words matter.
Yeah.
All right, I'm back to chest pain. I've gone
No. Thank you.
I've gone off on another thing.
It's needed.
And so atypical. So don't forget, it's atypical. And that also means that you as a woman and as a man and as society, you also haven't learned these symptoms, right? We watch TV, we watch things. Everybody has crushing chest pain, shortness of breath. They fall on the floor. We call 911. They have sweating, whatever, right? Nobody ever tells us that, hey, you might just feel run down. Or you might feel tired. You might have nausea. Or you might have jaw pain. It sends you to the dentist to check a tooth. Nobody tells you that. And then when you come to see your physician, they may not even recognize it because atypical really means might be hysteria, might be anxiety, might be, I don't know. It's a little nebulous, that kind of thing. That's why I say words drive thoughts and they drive action. And the things that we are tested on, the things that are reproducible are the things that we will act on and that we will remember. We are not tested on that. In other words, we are not held to accountability on those types of atypical things. And so the health system is also at fault. And so here a woman has these symptoms. She stays home for hours, days, weeks, longer than she should. Then when she finally comes to the medical establishment, they're giving the proverbial pat on the back, they're there. Here's an anti-anxiety medicine. Here's a panic or, whatever. Every now and I'm giving you this example because this is why physicians stay in bad situations longer than they should, because they know if they leave, people might die. They recognize. And it is such a hard and unfortunate position to place minority physicians in and to place women physicians in when we're looking and treating patients from a different lens. And had that patient not come to you, but for the sake of God, that patient may have perished or had a worse outcome that would have impacted them for the rest of their life. How can I leave and let that happen to people? Even though other things are happening to me that are making my life miserable. We have this all of the time. And so back to atypical chest pain. This is what happened. I know.
Yes.
It's a,
No.
and
Everything
so,
you're saying right now I'm telling you, it's the
right.
word. That's what we need to hear. Absolutely.
And so then when you come to the physician, what happens? You have a delay in getting to the cath lab. We know that every 30 minutes of a delay increases your risk of having a heart attack and losing more heart muscle. There is a longer and longer delay. Women's time getting to the cath lab is much longer than men's time. And then even after that, let's say you had a heart attack, you end up with revascularization, meaning they opened your arteries, all of these things. Only 72% of women will even be offered high intensity cholesterol therapy or high intensity blood pressure therapy. Only 72%, even through your event.
Mm,
So,
mm,
yes. So
mm.
we have a long way to go. I talk about these kinds of things all the time. The system doesn't work
Yeah.
for women. It doesn't work for minorities. And you only have to be a minority woman and a physician in the system to see it so glaringly. And, I reached a point in my career where I just felt that I could not speak anymore. But I will say this, that it was too long. And the reason I didn't speak earlier is because I didn't want to take the risk. I'm doing the risk balance ratio.
Yeah.
If I speak up and they banish me, then I'm no good to anybody. And so there was at some point where I got to my career, I just had to, speak up. So, and maybe you get to a point where you're just like, what are you going to do to me now? Or it may be that you find your tribe. You find an organization and people who are like-minded, whose values align with your own, and you have the support to continue to do the right things, because we came into this to heal people.
Right.
We're here to preserve life. And what happens in medicine oftentimes to minorities and women's is the antithesis of that.
Yeah. Absolutely. So, Dr. Moore, what we're going to do is I'm going to ask you just a couple questions to close us out here. What do you think the healthcare system can do better to address these disparities that we talked about? Because we talked about it from the standpoint of minority health, from the standpoint of social determinants, as well as gender inequities too. What are some things that you think in moving forward that we all can do, I can do, patients can do, et cetera?
Yeah, we need to have more principal investigators of research clinical trials who are Black. That means that the drug companies and research and pharma and biotech companies need to train physicians. They don't recruit. See, there's so many parts of this. They don't
Yeah.
recruit Black physicians to lead trials. We know the number one reason that a patient will enroll in a clinical trial is if she or he is approached by a trusted physician. That's any race, any creed, any culture. 80% of African American patients are seen by African American physicians here in this country for all the reasons I just named, right? We first pick people where we can trust them. We can trust that they will not first do us harm, that we can believe what they're saying. So if 8% of the Black population is seen by Black physicians, and almost 0% of Black physicians are trialists and lead clinical trials. And we know that the number one reason that a patient will enroll in a clinical trial is if they're approached by a physician. You can see where I'm going, where we end up with medications. We don't really know if they work for us or not. We don't really know what's happening. Currently there's a blood pressure medicine that I'm looking at more carefully, because it seems to me I continue to hear testimony and anecdotes that Black women, when they're taking it, start to lose their hair. Well, that's not a part of the side effects from the clinical trial profile. But when you look into it, they didn't really enroll Black women. So now here we are out in real world use, and we're losing our hair. When we take the medication, you talk to your doctor about it. What does your doctor say? Well, it's not one of the side effects.
Yep. It's in your mind.
Well, to a Black doctor, which is correct, right? So they're treating you to the top of evidence-based medicine.
Right.
But if you're with a Black doctor will say,
Right. Right. That's a big deal. Yeah.
is a big deal.
Mm-hmm.
And so we really need to have people in research. We need to have people who are leading research, like at these big medical centers, the chief scientific officer, the chief research officer. These are positions that need to be held by women, by people of color. It doesn't mean that white men can't have them. They can also have them, but your team needs to have people who have a 360-degree lens
Mm-hmm.
on your patient population in that hospital, and not just led by groupthink. Chief medical officer reinforces what the chief scientific officer is saying, or reinforces what the chief research officer, and nobody has any different ideas. So they just all congratulate themselves and never, not in a mean way. They just didn't know
Yep.
there was something else to think about because nobody brought it to their attention.
Yep.
And nobody brought it to their attention because there's nobody sitting at the table who's
Yep.
empowered, that they have empowered to bring it to their attention. And the
Yep.
last thing that I'll say is the most educated demographic in this country is the Black woman. Black women have the highest level of education and the most degrees in this country. And that certainly is not represented in jobs that we hold, in the places that we go, in the seats that we have. We don't have a place at the table. We work hard to get to the middle, and we can never get further than the middle. So listen to me, listen closely to what I'm saying. If you need to leave, you leave and go get your Black job. And you continue to maximize all of your achievements, because every place won't value you wherever you are. And even though I know you say, if you leave, this is going to happen to my patients, but once you can get out and achieve more power and more independence, you have the ability to influence externally. So don't stay for the sake of staying. Many of us do that. I get it, but just think about how all of that works, because we work very hard. We don't have the ability to pass down generational wealth. We never are promoted into jobs that are high paying enough. It determines the schools that your children will go to, the education they will receive, the housing that you can provide, the foods that you can choose, whether you can have organic or not. It's going to impact your longevity. Let me tell you something. Number one factor in the United States of America for long life is not good cardiac health. It's not, breast cancer. It's not, if you're a runner, a long distance runner, the number one indicator for living a long life is how much money you make.
Hey.
So when you look at Jeff Bezos and the heads of Microsoft, you don't have to know any of their medical history. But just the fact of their financial standing, they're going to live longer than you are.
Mm-hmm.
That's how America works.
Yeah, absolutely. Dr. Morgan, I appreciate you coming out and talking to us. I hope to have you on again, more so just for my own edification. I feel like I've been healed from this conversation. But definitely thank you so much. For our listeners, absolutely. Please be sure to check out Stairwell Chronicles, Dr. Morgan. Again, I'll post your app, because I definitely want to get that out to our listeners too.
Yeah, the Hello Heart app and hypertension. We are here to really solve that problem and to stand in the gap, especially for women's health, especially women in menopause. We didn't even talk about that today, and how your risk of heart disease increases. But get a chance, look at the Hello Heart app and follow Hello Heart. And you can follow me as well at Dr. Jayne Morgan, DrJaynemorgan. Submit a question. I might put it on my Stairwell Chronicle. Answer the question for you.
Absolutely. Absolutely. Well, thank you so much, Dr. Morgan. We'll be sure to talk about it next time. Thank you very much.
All right. Bye.
So that's it. I want to thank Dr. Jayne Morgan for coming out and speaking with us. I hope she comes out again and speaks further, because there's much more we need to get into. And I know I speak for a lot of folks out there to say that a lot of what she had to offer was very eye-opening and was very much what a lot of folks needed to hear, especially younger doctors in the beginning of their career, folks that are just now coming into knowing they have diabetes or high blood pressure, et cetera, and how we can utilize the medications that we take and some of the actions that we do in our day-to-day choices in terms of exercise, in terms of foods that we choose, if we have the choice to do so, that may affect our health in the long run. Please feel free to check out her featured content, which is the Stairwell Chronicles. You can check that out on Instagram, on TikTok, on X now, the former Twitter. So feel free to check that out. Also, check out her app as well. I will place a link to her app for everyone out there because I think that it's really good in terms of increasing our awareness in our health and keeping us on top of everything. That app is called Hello Heart. And again, I'll place a link to Hello Heart so that you all can get that on your devices. This is our first episode of season 2. This is your warning. Things are about to get real this season. We're going to continue to bring you content of this same ilk. I want to make sure that we get to the core of some of the issues. And to be honest with you, the only way to do that is to talk about these issues. It's not to skirt around them. And we're going to continue to do that in the next several episodes just because we can't keep doing the same thing over and over again. We have to come up with some meaningful resolutions to some of the issues that we're seeing over and over and over again here in the state of Wisconsin. Next month will be our next episode. And because we have some pretty monumental elections coming up, what we're going to do is we're going to bring you some topics that are going to affect your health in the state of Wisconsin. And so we'll have some very special guests that are going to be coming on to talk a little bit more about some of the public health issues and some of the public health legislation that is affecting the health of Wisconsinites throughout the state. So feel free to reach out to me if you have any other questions about this episode or about other episodes as you've been doing in the past. And we're looking forward to presenting that information. As an aside, what we'll be doing also is we will be putting information out there for anyone who wants to donate to a great cause for the Brain Tumor Foundation. There is a nurse that I work with. Her name is Chelsea. I'll put her information out there too, but she is, one of these superheroes amongst us that runs marathons. And so, my support goes out to her. She'll be running for the Brain Tumor Foundation. And essentially what this is a group of runners who come out and they will dedicate their run to increasing awareness of brain tumors as well as trying to garner support for research, garner funds for research, etc. And so brain tumors and cancers are things that affect pretty much anyone that you know, if you're not affected yourself personally. Having had a friend of mine in college, my good friend Rashawn Black, or Bo as we called him, who was a teammate of mine in college, unfortunately died secondary to glioblastoma multiforme. I want to make sure that we do all that we can to support brain tumor research and make sure that we do all we can to support folks who are doing things in the community in order to eradicate this disease process. So feel free to support her link. I'll put that out there as much as we can. As always, thank you so much for joining us. We're looking forward to seeing you in the next couple of weeks. And as always, take care of yourselves, take care of each other. And if you need me, come and see me.